Hey guys, I wanted to talk to you about a study that Jill Carson and I are doing on the effects of micronized fat tissue on um, knee osteoarthritis. And the reason why I'm calling out is because we need patients. We need to recruit patients pretty soon because we want to get as many enrolled by the fall. I'm going to give you a little I'm going to go a presentation on what it is, but the technique is called lipogens. We take a lipoaspirate or basically liposuction, and then treat it in a special manner to micronize it, to make it in small little particles, take out a lot of the oil and other tissue from it, and then inject that into the knee. It's a double-blinded study, which means I am blinded and Jill is not. This is for FDA approval. It's already been FDA cleared. I first started this and knowing this procedure when I went to Milan in 2017 to work with the guy that invented it. So it's been in the United States for a while. I've been doing a lot of it. I do think there's some advantages of it, and like I said, looking for your patients. So I'm going to give you a little slideshow of what we're talking about at this point. Um, Come on, let me share the screen. All right, so let's go here. All right, hopefully you guys are seeing this now. So basically, again, we're talking about a um, lipogens technique. This has been around for almost 7 years at this point, so it has been in use. Multiple procedures have been performed, multiple studies have been performed, but this is the one for FDA approval at this point. Um, just a little clinical background. Um, Uh, so basically, the purpose of the study is to study people with mild to moderate osteoarthritis. What we're not looking for is people that are essentially bone on bone in one compartment. We're not looking for somebody who doesn't have any criteria that would meet osteoarthritis, including if it was an osteochondral defect or the like. Um, they may or not be these are patients that are in that tweener stage that they've gone through all their conservative treatments but are not ready to consider total knee arthroplasty at this point. And again, we're looking for a total of 173 patients. That's over all sites. We're looking for about 25 to 30 in our site. It'll be a total of 6 months follow-up. And the good news of this double-blind study is that treatment versus placebo is a 2-to-1 rather than a 1-to-1. So that's kind of an advantage. And again, we're trying to treat the people with osteoarthritis. And again, it's unilateral osteoarthritis in that gap, in that treatment gap where patients are suffering. They've tried everything, including cortisone injections, viscous supplementation, medications, physical therapy. They've gone through all that, but still have that issue. And it's a very expensive problem in the United States right now. And we're trying to come up with some techniques to help that. And so why are we using adipose tissue? Well, we know within adipose tissue, there's a lot of mesenchymal signaling cells within this. There's essentially, we feel there's more in adipose tissue than there is bone marrow. These are the two resources we have to get autologous, we'll call them stem cells, but the mesenchymal signaling cells from any individual. This is, it's a tends to be a less painful technique than getting bone marrow. And again, there's a chance that there are more growth factors and restorative factors in adipose tissue than there are in bone marrow. So lipogens, basically what it does is takes the fat tissue and then uses a minimally manipulative device to kind of separate the actual fat globules from all the other tissue that's within the adipose tissue. Um, Couple things that you could let your patients know is that it is FDA cleared for orthopedic and arthroscopic surgery. There's already been over 60,000 procedures done worldwide, and it's available throughout the United States. And there's been, like I said, 150 peer-reviewed publications supporting lipogens in various pathologies. Um, so what we're trying to do is actually get FDA approval for this and not just FDA clearance. What's the difference between just using fat and micronized fat and adipose stem cells? Well, with what lipogens does is what we call microfat, and that's how we say that's how we're treating it. We're not treating it with stem cells, we're treating it with microfat. And what's within this clump of microfat is all the restorative elements that are within the fat tissue, not only mesenchymal stem cells, but also exosomes, also pericytes, and other signaling proteins that help to control the microenvironment within the knee and around the knee, and hopefully decrease the progression of osteoarthritis. The reason why we're not using adipose-derived stem cells themselves is because we're not allowed to in the United States, because we can't manipulate the fat to get the cells out, and we can't culture the cells once we have them. So it's one of the problems we have with the FDA. With anything we use needs to be minimally manipulated. So study protocol, again, it's multi-center study. It is for KL grade 2 to 3, which is an antiquated scale. I hate it, but it is what multiple studies on the effects of product on osteoarthritis uses. It is one of those things that unfortunately we have to use. The amount that we'll be injecting in each knee is about 7 milliliters of microfat into the affected side through a under ultrasound. The placebo would be 7 milliliters of saline into the affected knee. Again, it's a 2-to-1 ratio. For screening purposes, these patients have to have failed treatments. They've had to have at least 3 months in their history. Again, this is not just now, this is within the history, a 3-month history of use of non-steroidal anti-inflammatories, Tylenol, and other pain medications, and with substandard and benefit. They have to have, again, a total of about 6 weeks. They say 3 months, but it's 6 weeks to 3 months of physical therapy, whether that be something that you just give a handout for or whatever. Over their time that they've been dealing with osteoarthritis, they've had at least 12 weeks of physician-directed physical therapy. Inclusion data, they have to be over 18 years old. They have to have the clinical findings on X-ray, which is, believe it or not, it's a standing AP. They don't include the PA, but a standing AP has to show some evidence of some osteophyte formation on it, and at least some evidence of some type of joint space narrowing, but it can't have more than 80 to 90% joint space loss, because then it's beyond what we would want to use. They have to have persistent pain despite conservative treatment. They need to be everything else needs to be well controlled. Hypertension, diabetes, all other medical problems must be taken care of. They must be willing to stop taking any prescribed pain medications or any other medications other than what is authorized by the study for 6 months. So if they have something else going on that they need the pain medication for, that they're unwilling to do that, well, then they can't be in the study. Similarly, it's got to be unilateral. Okay, so there's got to be a major difference between the affected knee and the non-affected knee. It doesn't mean the non-affected knee can't have osteoarthritis, but it has to have a low, the unaffected knee has to have a low WOMAC score, a score below 6, and the symptomatic knee has to be above 10 or 11, I believe. So there's got to be a major difference between the two. Now, what's excluded in the study are people with no signs of arthritis on their AP view, standing AP view, and no complete loss of joint space. Here's the stuff that's really hard. It's the first time I've been doing a study like this that has limited to this, but the BMI has to be under 35%. I know so many of our osteoarthritis have BMIs above that, but for this study, that's exactly what they're asking for. So that's an exclusion if they're above. Any local or systemic infection, obviously we can't use. Any allergies to anesthetics or cortisone, we can't use. Any autoimmune disorders, inflammatory osteoarthritis or coagulation disorders, we can't have. Any problems with, again, inflammatory osteoarthritis. Uh, Also, no previous tumor therapy or history of cancer within 5 years. Can't be an active workman's compensation case. I don't know why these are doubled. Women with a positive pregnancy test or who may get pregnant over those 6 months should not be in the study. And injection, it's follow up for at least 6 months, and no planned upcoming surgeries on either knee. So that's what's going to be. Sorry about that last slide. I guess I didn't check it. Again, emphasize patient has to be willing to stop prescription pain medications or prescription anti-inflammatory medication during the study, other than what we can actually give to the patient. And that's part of the criteria. If the patient is very thin with little adipose tissue, they may not be a good candidate for the study, although we could usually get enough from love handles in the back. And the location of the fat harvest really depends on where they present. And again, this harvest will take place in both people that are getting the placebo, the saline, as well as the people that are getting treated. So that's something you have to warn them about as well. And so again, as we talked about, any other osteoarthritic conditions of the spine, of the hip, of the ankle that affects them, that would alter their ability to recognize how much pain relief they're getting in the knee itself is something that we can't, is an exclusion as well. Obviously, anybody with just asymptomatic spinal stenosis or asymptomatic diagnosis of osteoarthritis in other joints is really fine. Again, the way it works, it's about a 6-month duration. You have a screening day to see if they are indeed a candidate. Then you have the treatment day, which is just the procedure, and then the follow-up visits. And again, everything's going to be done with informed consent. We'll go through the exclusion criteria and all that. We'll have the WOMAC scores performed. We do some other medical evaluations for these patients. Obviously, it is free to them, and they get reimbursed for their visits. I'm not sure. I don't think I could say to you what the reimbursement is, but they do get compensated for their time and participating in the study. And basically, we just look for the selection of harvest sites. We're working where there's good fat tissue. We'll often use ultrasound to check where a good specimen of fat is. Then we'll infiltrate with a combination of saline and lidocaine, and then we'll do the harvest, which is actually just liposuction, and we'll get anywhere between it says 70 cc's. It's usually a bit more than that, just to make sure we can get the 7 cc's that we need to inject. It should be noted that we already do this in the clinic. We already do this right now in our in the office. We do take adipose tissue in the office already. So it's not something we can't do outpatient in our procedure rooms. And basically, this is just it's a closed loop system that it stays within the sterile system. It goes through multiple washes, and you end up with some really good specimen to inject into the knee. So and then the injection, as we talked to you about, going through ultrasound guidance intra-articular into the knee. So if you have any questions, let me know. We're going to, let me just show you another, and I'll have this on the email as well. Hold on. Come on, where's my I do want to say, so where we are doing this, hold on. Come on, open up. I want to get screen share. All right, so where we're doing this is at the Lehigh Center for Clinical Research. The patients just need to contact them and tell them they're interested in the osteoarthritis study, and they'll be asked some questions, and go from there. Any questions, let me know. Look forward to having your patients screened and hopefully be able to help them with what would be a very expensive treatment, and would help get this through FDA. So it'd be great. So if you have any questions, let me know. Please, we need the patients, and we need, again, unilateral patients with a fairly significant pain without, severe bone on bone or over 35% BMI. So I appreciate, and hopefully we'll see some of your patients. Thanks.